Hello, everybody, and a very warm welcome to Stewarts Soundbites. I've lost track of the episode number, but I am delighted to be here today with Dr. Nicholas Silver. Dr. Silver is a consultant neurologist and an excellent medical legal expert, and I'm really looking forward to this session. Just a note for everybody, this is a pre-recorded session. So it'll be available on the website after we've recorded it, and we won't be able to answer any questions live, but if you do have any questions, then please submit them in the Q&A box and we'll try to respond to you after the session is aired. So today, we thought we would talk a little bit, I thought I would question Dr. Silver a little bit about kind of distinguishing treatable symptoms after traumatic brain injury. And we were just talking about this before, weren't we, Nick, about this kind of came from a conference that we had and talking about a client and about fatigue and the different reasons why clients might feel fatigued after a significant brain injury. And you know, Nick, you kind of said to me, well, you know, it's not just fatigue, it's cognition, it's sleep, it's lots of different symptoms, and a lot of us kind of take it for granted that these are just kind of standard symptoms that arise after a brain injury without really applying ourselves to the reasons behind them. So I thought that would be an interesting topic to discuss today. So I mean, starting with fatigue, just because it's such a common symptom arising from a traumatic brain injury, all of us that work in the field are familiar with that, and it is often a really pervasive aspect of someone's presentation. Is there an overarching neurological explanation for cognitive fatigue, or does it manifest differently in everybody for different reasons, depending upon the type and the extent of the brain injury? And I'm aware I've asked you about 6 questions there, so sorry.
Okay, thank you. And thank you for asking me, Emma. So I think when we think of fatigue, we have to think about what patients say and the things that would make them feel fatigued. So it could be fatigue could represent different things, from tiredness to boredom to depression to loss of self-esteem. And the actual overall component of fatigue, it can be a physical fatigue, it can be a mental fatigue where your mind is going through treacle, or it can even be a daytime somnolence fatigue where you're actually properly physically sleepy. So I think you have to try and dissect out what the type of fatigue is that you're looking at, especially separating out the daytime somnolence fatigue from the cognitive fatigues. And then once you do that, I think you have to think about where this is coming from. So for instance, it's very, very well recognized that brain injury, especially with a significant frontal lobe impairment, will cause fatigue as a major symptom. But yet if you've got a cognitive component without much in the way of frontal symptoms, and you're having to struggle a lot with your cognitive thought processes, then you get more worn out. And everything is, again, it's like going through treacle. It's really hard to try and keep up with things. You're putting in much more effort than you would if you were just running on autopilot. And then if you're looking at the physical types of fatigue, which can also impact on the mental fatigue, you've got to look at sleep disturbance, which can be directly secondary to the head injury. I think restless leg syndrome and periodic limb movements are highly common. I think they're present in over 70 to 80% of people that I see who've had a head or brain injury, including people with minor cognitive injury or mild head injury who have developed a headache syndrome. I think poor sleep can come about through post-traumatic headache syndromes. And there's not just one, but all of them can cause a fatigue syndrome and problems with sleep. Then we've got the other treatable components, things like pituitary function. Your low growth hormone is a classic example, and you may be looking at 20 to 25% of people with a significant brain injury who are going to have a pituitary dysfunction according to the literature. I must admit, in my clinical experience, I think it's actually quite a lot less than that. But if you've got pituitary dysfunction and you can replace hormones, it's really important. Growth hormone, cortisol, thyroid. And then you've got the psychiatric disorders. Anyone who feels depressed will often feel fatigued. And depression and post-traumatic stress disorder are really, really common, especially seeing some of the mechanisms of injury. So what it comes down to is, out of all that sort of group, which I normally think of separately, and I take each one separately when I'm looking at people, I'm thinking, what's treatable? Well, from the head injury and the sort of the brain injury side, yes, you've got all the occupational therapy, the pacing, the resting, And that's really important, the lifestyle from that point of view. But from sleep, if you've got a sleep issue following a head injury, the simple thing that you can do is just cut out all your caffeine. Completely cut out every bit of tea, green tea, coffee, cola, Dr. Pepper, Red Bull, Iron Brew, Lucasade, chocolate, drinking chocolate, cut them all out completely, and cut out painkillers, because they will keep poor quality sleep and restless legs going. You can use drugs for that sort of fatigue, especially if it's a sleep problem with restless legs or poor sleep architecture, if you're not going into the proper sleep cycles. Drugs like gabapentin or pregabalin at tiny dose at night, say pregabalin 25 to 50 milligrams for 8 months, and then come off it. You don't want to just add drugs in and leave them there, but 8-month course of pregabalin can be phenomenal at getting sleep architecture back into deep sleep. Stopping the drugs that all the other experts want to give, like antidepressants. All antidepressants, maybe with the exception of trazodone and bupropion, cause sleep disruption, and they stop you going into normal sleep architecture. So it's what you take regularly, like antidepressants, that are going to ruin your sleep cycle and make you more fatigued. But also just being aware, this is for other people out there anyway, just even if you haven't had a brain injury, if you feel tired, be aware that a single dose of caffeine is going to have an effect on disturbing your sleep for the next 7 days. So caffeine is going to affect your sleep through brain receptor mechanisms, not just the level of caffeine in the blood. So you want to stop caffeine, and for a week or so, you're going to get headaches and bad sleep. But then 40% of people will find that their fatigue and their headaches and whichever parts of that they've got are much better. 60% will disappear, their restless legs will disappear on stopping caffeine. That's the first treatment. So just, even if you don't have a history here, stop your caffeine and stop your stimulants in your patients. Stop your painkillers if at all possible. And if you have to find restless legs, check the iron, B12 and folate. If ferritin is less than 50, B12 is less than 300, or folate is less than 6, really vigorously replace, 8 months of iron or a year of B12 injections, etc. If you've got a headache disorder following the head injury, which is common, treat that, because once you treat the headache disorder, you treat all the non-headache symptoms, which include amplification of noise, light, smell, sound, touch. Everything becomes amplified. Your concentration gets reduced. You get neck aches, you get back pain, you get widespread pain. You get dizzy, you feel dissociated, you feel detached, you can't connect. You get vertigo, you get low mood, irritable mood, emotional mood, your memory goes, you can't think straight, you get stuck halfway through your sentences and you come out with the wrong worms, okay? You put things in the wrong place. So that you get, all those symptoms you get, and restless legs, you get just by having a headache disorder, even if you hadn't had the brain injury. So the brain injury comes and triggers a headache syndrome. So it might be the trigger, but you need to treat the headache syndrome. And I'll come back to headache syndromes, I think, with your other questions in a minute. But essentially, look at the patient holistically, simple things you can do and simple things you can assess.
And presumably then, and like those simple things that you can do, like cutting out caffeine, which terrifies me. I'm a terrible coffee drinker, but doing those simple things.
If you feel you need the caffeine, that's the answer that is causing a problem. If you feel tired and caffeine picks you up, it's not because caffeine is a stimulant, it's because the caffeine was wearing off and you actually need to replace your levels to keep your levels up to normal. But when they're starting dipping, you get subfunction, and you're not thinking straight, your concentration goes and you get tired, and you only replace the levels up to normal. But if you come off it, you'll be as good as not on caffeine all the time.
Yeah, wow. And I suppose that'll well, this is it, and it's so interesting because I mean, just by doing those simple things, then I suppose it's like a kind of process of elimination, then, isn't it? Because then you're eliminating the possible causes, and if you're still left with fatigue and you're still left with these problems at the end, then you move on to the next thing, which is a helpful kind of practical.
When you take a story, when you actually assess someone, you want to ask them about their sleep, but not just about what time do you go to bed and what time do you get up and do you use screens at night, which, yes, are important things, and your sleep hygiene and good ventilation and good blackout blinds, that's important. You want to ask whether someone has difficulty getting off to sleep, whether they get any symptoms of restless legs when they're going off to sleep or jumps in the legs, whether they feel they're waking up a lot at night. If they're dreaming more than once a night, we all dream 5 times a night or so. You only remember them if you've woken during the dreams. So if you're dreaming more than once, it tells me that they're constantly waking up through the night. So instead of going through that nice, deep, slow wave sleep cycle 5 times at night, they're just shallowly suppressed beneath the surface and you need duration of sleep, 8, 9, 10 hours, depending on what your age is, and you need the quality of sleep. And if you're not getting through that proper cycle, or the sleep cycle is fractured at times, you'll know this with a 1-year-old. If you're woken up in the middle of the night, you could have had a great 8 hours, but that once being woken up makes you tired the next day.
But you feel knackered,
So your sleep cycle, if it's fractured once or twice, and you get breaks in there, or if you're not going into deep sleep and you're just shallowly sleeping, you'll be tired, because the quality of sleep is really important.
I was going to ask you a little bit more about the different assessments and things that can be undertaken, because I know that you've given some amazing practical things there for people to think about, actually, and not just people who are injured, but their carers and their case managers and all of their team to really give consideration to these extraneous things that may be impacting. And I wanted to ask a little bit about kind of other simple assessments that we can carry out as well.
Fine. So I think it still comes down to story more than machines. So it's about asking those questions for sleep I just asked about. It's asking not just, do you have headaches? Because patients may say no, but how many days of the month are you crystal clear and headache free, where there's no discomfort or pressure in anywhere of the face, head or neck? All the areas that we see in headache disorder, because they'll often only tell us when it's bad. So you want to find out, and you want to find the nature of the headache and divide it in. If you know which type of headache syndrome it is, you can then treat it properly. I think a lot of people rely on Fitbits and other, Apple Watches or whatever the other things are, if we're allowed to advertise. I'm not advertising, I've got a different make completely. But if you set things to your sleep pattern at night, or even put your iPhone onto your pillow, then you can see what the actigraphy is like. You can see it's not a perfect sleep study, but you can see if it's got lots of little bars in it that are telling you you're constantly being roused. That's another example of needing to stop the caffeine and painkillers, and to think about low doses of pregabalin or gabapentin at night, and come off antidepressants, because they're going to make it worse. You can tell these people, they're the ones who, when they start antidepressants, they feel more tired. I think assessing cognitive function, obviously you have to do. You want to see if there's a frontal lobe injury, and that you're going to get from the questionnaires and the relatives and the witnesses. You're going to get that from the actual cognitive assessments. But it's a really difficult thing. Cognitive function is hard to find, and it's more from the witness accounts than what you will see on neuropsychological tests. If you've got someone who's less active because they've had multiple trauma and they put on a lot of weight, don't forget to look for obstructive sleep apnea. I mean, if someone's falling asleep in the day and they've put on weight and they've got a bigger collar size, get a 24-hour pulse oximetry study just on the finger, because if they've got sleep apnea, they need a CPAP mask. And then don't forget to do the pituitary. Everyone with a head injury should have a pituitary function screen. Checking cortisol, 9 a.m. cortisol, IGF-1 for growth hormone, T4, TSH. In women, checking LH and FSH, testosterone, T4, TSH. Everyone should have that as a basic. And if you're not sure and it's a bit dubious, then you get them sent to an endocrinologist to do a dynamic study and really stress the pituitary to doing more. And in all patients, before you even start investigations, get them off the caffeine, off the painkillers, if you possibly can. Long-term painkillers for long-term pain conditions are not a good idea. They're very good for an episode of pain. But longer term, all they do is switch on this central sensitization process that's got migraine at its heart. And they keep all the fatigue, the widespread pain, the concentration, the memory problems going. And you just end up building more and more painkillers in, and the patient becomes a bigger and bigger iatrogenic mess, and you won't get them off that. Once you've switched on all these receptors, it's very hard to take them off. And then obviously make sure they've got good sleep hygiene. Avoid the screens after about 10 o'clock at night. You want a good hour without the shining lights in your eyes, and you want to get out in the morning to sunlight when you can, because it gets the proper sleep cycle in place. So all of those are worthwhile. And the blood tests, as I mentioned, for hematinics, if you've got restless legs or B12. So that's the sort of studies I would do.
It's really interesting, because there's a whole host of things really that you can use this kind of elimination process, isn't there? And I presume that in organising that sort of assessment, the best thing to do, I guess, is to ask your GP, speak to your case manager, and start from kind of a practical level.
I think this is where the case manager comes in, because the trouble with all of these cases is that there are conflicts of interest. There's the conflicts of interest in terms of trying to settle the legal case, and then there's trying to get medical care. And patients fall between those two stools. They don't get the private care because they're waiting for the interim payments. They don't get the NHS care because the GP thinks they're under private care because they've got all these people privately funded by insurers. And everyone backs off. And at the same time, you then get different experts on different sides, all giving different opinions, and all being, they all say opposite things. The psychiatrists tell you need antidepressants, and as a neurologist, I'm saying stop antidepressants because they're going to be short-sighted. And if you look at mood, if someone's got a post-traumatic headache disorder, look at mood. If they get the occasional time where they are headache-free, ask them what their mood is like on that day. Ask them what their fatigue is like on that day. Because if they've got if they get a brilliant day once a month where they've not got a headache and they're not fatigued and their mood's not a problem, their fatigue and their mood problem is part of the headache disorder. And that is not going to be helped with antidepressants. That's going to be helped by treating the headache disorder. And antidepressants are a really bad treatment for most headache disorders, even though they're standard in the textbooks, because they destroy sleep. So if you're going to have to go for antidepressants, go for ones that don't destroy sleep. Go for the ones I mentioned before, the trazodone type options. And that's what I would suggest in those. You want a case manager to try and coordinate. You want to get ideally you want to get under a holistic clinician that can look fairly wide for these things. Unfortunately, most of my neurology colleagues tend to say if they're treating sleep disorders or headache disorders, they just treat those rather than thinking about the whole wide picture. And it is really hard to get, if I'm an expert in a case and send them to another headache specialist, I often find they've just taken a little bit of it and ignored the rest of it, and it doesn't do the patient any favours. There is actually, if you have a post-traumatic headache, there is actually a booklet that I wrote for the NHS Vanguard, which is www.bit, Bravo India Tango.ly Lima Yankee /migraine booklet. So www.bit.ly/migraine booklet. And that will give patients all that lifestyle, and it will tell people about how the headache disorders interact with sleep disorders. So, after a brain injury, you can get headache and sleep disorder, or you can get sleep disorder on its own, but very commonly you get both.
Wow, we'll make sure, Nick, that link is at the end of this discussion. There'll be a slide that will come up, and we'll make sure that that's linked in, so that people can access that. That's really helpful. And we're running out of time, but I could talk to you forever about this. It's so interesting. I just wanted to ask you a little bit more about. I know that we didn't really plan to talk that much about headache disorders, but I think it's a really important topic actually, and I think that it is something that's potentially sometimes overlooked. Is that your experience, Nick?
Hugely overlooked because it's not often the main symptom. The main symptom is maybe the cognition, the fatigue, the behaviour change, or the pain syndrome. And actually, you've just got to be aware when someone's talking about a headache syndrome, it doesn't mean the pain has to. First of all, you can have a headache syndrome without any headache. Just to confuse people. So if you've got someone who's more sensitive to noise and light and smell, even if they're not complaining of headache, if they're dizzy, if they're fatigued, think of headache syndromes, think of post-traumatic migraine and the other headache syndromes. If someone's complaining of pain in their neck and back, that's very common in a headache syndrome. If someone's complaining of numbness, weakness, heaviness and tingling down one side, that's very common in a headache syndrome. So when you've got the patients who don't seem to be fitting the rules and the experts are saying they're functional or they're swinging the lead or whatever, just think about those things because they often happen in a headache syndrome. And I think you have to think about which headache syndrome it is. I think one of the commonest ones is post-traumatic hemicrania continua, one-sided predominant headache, jabbing, stabbing pains when they're bad last for a day or two, maybe longer. Pain never goes. When it's really bad, it may go a bit to the other side. That's often because they're taking lots of painkillers and it makes it more bilateral. They get red eye, runny eye, droopy eye, blocked nose, runny nose, fullness in the ear, flushing and sweating. And so they end up being like ENT and people think there's a problem elsewhere. That's very, very treatable with nerve block injections from a neurologist specializing in headache. There's also a gamma core, a vagal nerve stimulator that can be really effective. And then we sometimes use drugs like indomethacin. I'm not a fan of those because they cause a lot of side effects. The second, I think, type of headache disorder is post-traumatic new daily persistent headache, which is often migrainous. and that one needs treating like migraine. You stop the painkillers and caffeine and give migraine preventatives and new treatments like Botox, CGRP monoclonal antibodies through your headache specialist. So a headache specialist is key. Just occasionally it's cluster headache, and that's a real nasty one. That's suicidal ideation.
Yeah.
So
Yeah, for sure.
Get them seen by a headache specialist if there's any headache there.
Yeah.
Rehab clinics aren't often used to that, the headache side. They will let them take painkillers. We don't, and we get them on the right preventative strategies.
Yeah, and from a practical point of view, I suppose it's interesting for the type of clients that we deal with to speak to their case managers and their family and monitor really closely not only their bad days and their awful days where they've had terrible sleep, and but actually to record how they're feeling on their good days, and use that kind of self-reporting as a way to eliminate potential causes of all of these problems.
Practical. I mean, obviously, if you've got someone with a persistent headache, you're not going to see that as much. But if it fluctuates and they get really bad and really good days, then you will see that. The other thing that I don't forget, the psychiatric and psychological disorders really interrupting sleep and causing fatigue. And I think it's very hard to treat the comorbid headaches. It's very hard to see someone with post-traumatic stress disorder after one of these accidents or a head injury who doesn't also have a headache disorder. They go hand in hand. But that needs treatment. You'll never get the patient better unless you get the PTSD sorted out. So that needs early attention with ideally EMDR therapy or CBT. But so often that's not accessible in the NHS, and it's really important if there's a hint of PTSD to manage that, because if you don't get that out of the way, it's often a stumbling point and the patient doesn't get better.
And is that before? And do you manage that side of things before coming on to the headache disorder then, or can treatment be concurrent on those? It can be concurrent.
And if we've got an emergency situation with someone with really severe headache syndrome, then we can do nerve blocks, which can work quite quickly. I mean, I think it's important for those who don't realize it. You can get a really severe headache syndrome following the most minor of injuries. So a whiplash injury, which is quite minor, no loss of consciousness, no brain injury, is enough to trigger a headache disorder, post-traumatic migraine or hemicrania continua. So the headache disorder isn't often the mildest ones are the ones that get the mildest head injuries are the ones that get a lot of headache disorder. And this is, I mean, if you want to open a can of worms here, the number of cases of whiplash that I've been involved with where the other side has said it's whiplash, and actually what we've diagnosed is a post-traumatic headache disorder with proper International Headache Society criteria, absolutely ballpark criteria, all met for a headache disorder, yet they're being written off in the courts as a trivial whiplash injury, yet no one's giving them the right treatment because no one's making the right diagnosis. So there's a huge can of worms out there. I know a lot of whiplash cases have gone elsewhere because of the rulings and things, but there's so many patients with whiplash out there who it's not whiplash, it's a post-traumatic headache disorder, and you can get that from a brain shake. And we don't just see that in legal cases, we see that in our clinical practice where there's no legal case to answer.
Yeah. Wow. I mean, I'm absolutely gutted because we're out of time. Well, we're over time, but I think it's worth it because it's so interesting and it's so important. Those everything that you've talked about is just so interesting, and I thank you so much, Nick, again for coming on. And I might have to drag you back kicking and screaming to do a part 2 because I think it'll be demanded. But thank you so much for your insight today. It's hugely appreciated. And as I said, because we haven't got the opportunity today to answer any questions live, if anyone does have any questions arising, send them to me. Or you can type them into the Q&A box and we'll receive them at Stewarts and we'll sort out a response for you. But thank you ever so much again, Nick. I really do appreciate it.
That's a pleasure.
And oh, thank you. And next week we'll have our international injury team doing something a little bit different, so make sure you tune in for that, and we'll look forward to seeing you soon. Thank you.